2006. I've been doing that work here at Michigan State. And before that, I got my start in 1989. We spent a month where my wife grew up, the Democratic Republic of Congo. That was following a sabbatical year at the University of Michigan, where I was interning in brain imaging and neuropsychological assessment. And then so since 1989, we've been pioneering neuropsychological assessment in the Sub-Sahara, really before it became widely of importance as a measure of morbidity. Before that, it was just pretty much about keeping kids alive to age 5 within public health interventions and in the face of a multitude of different risk factors, many of which Emily mentioned to us. Okay, we'll advance. So in 87, I got a chance to spend a year and then continued really there up to the present time with my adjunct appointment at Michigan. Brain imaging, they had one of the, prior to MRI, there was positron emission tomography of the brain, and they were one of only 6 PET scan centers in the nation, because you had to have a cyclotron in the 80s, spin your own particles for isotopes to do your radioisotope labeling in order to image living, normal functioning brains. And so we did quite a bit of work in neurodegenerative diseases. They needed somebody to help with the image analysis and the neuropsychological analysis. And I was just down the road at the time. I did windows, did floors, paid for my own gas, and I was easy. I wasn't too demanding, and so we had a lot of good years, really up to the present, with Bruno Giordani, who's second author here, and you'll see a picture of him shortly. Advance. I got interested around that time in a holistic approach to individuals that might be of interest here at the People's Church. Andrew Newberg at that time was at UPenn, but then later at Thomas Jefferson University, a physician who was interested in brain imaging and spirituality. And we began applying that to breast cancer survivors and patients. I started that work in Indiana before coming to Michigan State with my undergraduate students, because there were opportunities there and some limited funding. And then was able to leverage that preliminary work from Indiana into a Templeton Foundation grant just before coming to Michigan State in 2006. Advance. So really, we did brain imaging of picture activation, spirituality, happy, sad, neutral pictures in breast cancer patients, and benign counterparts matched to our breast cancer patients, newly diagnosed. And that was really my night job. And though I was hired to Michigan State to work in Africa primarily. Advance. But what drew me to Michigan State at that time was really a core aspect of their mission, which was from going to a land grant to a global grant with a global reach in terms of meeting human need. And many aspects of that are embedded within our strategic plan, newly revised and implemented this year under President Stanley. But early on, what really drew me was that global grant, global health mission and vision within the medical colleges, especially. Advance. So that led up to the present time. I'm professor and director of our Global Neuropsychiatry Research Center. We're the newly appointed center. We've been able to develop a group. And if you go to this website, Global Neuropsychiatry at msu.edu, or just search it on the MSU website, you'll be able to see a lot more about our present activities. So from those beginnings with breast cancer and individual projects in the Sub-Sahara, here at Michigan State in 2006, in the aftermath of 2 Fulbrights, one in the Congo in 1990-91, and then followed by a second in Uganda in 2003-04. I'll talk more about those in a bit, where we've kind of evolved into our present day research center in the College of Osteopathic Medicine. Advance. So our mission is to develop and validate innovative strategies within neuropsychiatric science designed to enhance healing and wholeness in the face of human affliction and brokenness in individuals, families, communities, committed to alleviating human suffering in the context of global mental health, human development, neuropsychology, neurodevelopmental assessments, and interventions as well. Hoping to be a part of becoming and continuing to be a premier global reach institution. Continue. Now, how did all this begin? I was trained as a rat runner, an experimental psychologist. My dream job was going to be working for a large pharmaceutical, pumping new drugs into rats and seeing how these pharmaceuticals could make a lot of money on a new generation of anxiolytics and psychodynamic drugs. And we then I met my wife in graduate school, stole her away from the Peace Corps. She did get back to Africa, but it was 10 years and 4 kids later on her 1989, followed then by a year back in the Congo. She grew up in the Congo. Her father was a medical missionary. Lost the use of his left arm to polio, treating an infant with polio in the early 60s, so he'd been vaccinated. So he retooled in public health and spent the rest of his career up to fall of 91 doing public health work, and actually probably saving a lot more lives in terms of his impact than he would have as a physician training other physicians in surgery. Advanced. So it was really that year, that Fulbright year in the Congo, 1991, my letters home became kind of memoirs that a prior university at that time published for use by their students in their cross-cultural class. Now, it's out of print, as you might imagine, but I don't know, you could still pick up the occasional renegade copy on Amazon. The Accidental Anthropologist. But if you go to a Thrive Early, spelled as it sounds, Thrive Early, no space, on the MSU website, it has another feature on our research. And on the cover page, lower right-hand corner of that, you can download a free copy of in PDF form of this book. Michigan State University obtained rights to this book from the publisher that went out of business, and we were able to make it available to you for free if you're interested. Advance. So my first team in the Congo, these were actually high school level teachers who I trained to do the neurodevelopmental and neuropsych testing at that time. Called task shifting in the business, where you get, when you don't have trained professionals or paraprofessionals to do what needs to be done in neuropsychological assessment, you try to use tests that you can train whoever's capable and willing to learn. And we've trained a lot of nurses since then in a host of other countries, and most recently in Uganda and Malawi. But at that time, that was my assessment team. We traveled all over the western part of the Congo, doing a number of different studies, looking at neuropsychological outcomes of exposure to pediatric HIV, severe malaria, treatment for intestinal parasites, treatment for malaria, treatment for severe anemia, malnutrition, on and on. Continue. That was a small Catholic mission just down the river from our Protestant mission, where my parents, and my in-laws, I should say, were based, and before their retirement. And there, a nun, American Sister Agnes Marie Gallagher, who passed away shortly after the Congolese Civil War, when they moved her to Cameroon, and then died of exposure to a new strain of cerebral malaria. But at that time, she and I collaborated with our team, looking at interventions for intestinal parasites, malaria, anemia, replicating a lot of the results that we had done in the area surrounding, the village areas surrounding the Protestant mission, just upriver, and publishing those results as concurrently. Continue. But at that time, that's when I got to look at the early days of HIV and what it was doing before any treatment was available, before we really even fully understood it in the Sub-Sahara. wasting disease that we saw in women who were affected, especially when their partners came home from the city infected at that time. And that, again, was the beginning of the spread throughout the rural areas, and then the pandemic at that time throughout the Sub-Sahara. Advance. Here's one of our women and a perinatally infected child. At that time, there was no real way to prevent perinatal infection. And probably a third to almost half of our women with HIV would transmit gestationally, perinatally to their child, or through subsequently through breastfeeding. We didn't understand the process at the time. Now we can reduce that to less than 0.5% with good combination antiretrovirals, but at that time there just wasn't any way to really effectively prevent perinatal vertical transmission. Advance. And so we looked at the impact of quality of home environment on infectious disease from perinatal HIV plus other kinds of severe brain infections throughout early childhood. Adjusting our neurodevelopmental and neuropsychological outcomes for quality of home environment, because over the long term, that has a huge impact, as we well know. Advance. And then assessing, how to assess quality of home environment. And this, 1990, it was kind of a new game, but we did the best we could, adapting a number of different measures, not your traditional sort of socioeconomic status measures that are even used here to characterize on the basis of income or zip code or neighborhood, but really on the basis of material possessions, and then in a physical examination of the home environment, source of water, source of latrine facilities, food preparation facilities, the physical habitation, density of habitation, and so on, which really important in characterizing the kind of conditions that a child lives in from very early years through early childhood on into school age and beyond. Continue. I was at that time in the Congo. I got to look at Konzo disease, which I've been working on up to the present time. It became my master's in public health thesis topic after my Fulbright year in the Congo. I finished a master's in public health at the University of Michigan through their OJOC program, on job on campus, where I could keep teaching psychology at a nearby university, but through a 2-year, very lockstep structured program at the University of Michigan, finished my master's in public health. And my thesis requirement, which was wide open, it was a generic program, but I could provide a global health African spin to it in my optional assignments. My thesis then was Konzo disease and ecological analysis. And in fact, we're working on Konzo disease now in the Sub-Sahara through the support of NIH up to the present day. Advance. So our first major publication in this area more recently, in the journal Pediatrics in 2013, where we were the first group to establish that there are neuropsychological effects to Konzo in school-age children. Konzo disease, which is a result of exposure to the cyanide within their basic food staple, cassava, when the cassava is not adequately processed, in near famine conditions, when it's their only food really to subsist upon. And that was the case during periods of hardship and in many impoverished areas with ecological degradation. Without sources of protein to help the liver detoxify the cyanide from the cassava, with poorly processed cassava, within even a matter of weeks, children, adults, mostly moms and kids, because they're they get the last dibs of whatever protein might be available, sadly, but they're the most vulnerable to then a permanent neuromotor disease affecting the upper motor neuron pathways, partial or more full-blown paralysis of the lower limbs. That's irreversible. And the key then is preventing it. And that's what we're working on now, how to train moms in the prevention of Konzo disease, even and through safer preparation, but also through caregiver training and sensitizing them to the effects of these toxins in their food staple. We're the first to establish that there are neuropsychological effects. Before it was thought to be, when WHO characterized this disease in 1996, it was thought to be a purely neurological disease. And we were the first to establish that even subclinically, even before the neurological symptoms, there are permanent long-term neurocognitive effects and neurodevelopmental effects when we looked at that more carefully in younger children. That work again and preventing CONZO, subclinical and clinical, continues up to the present day. In our partnerships with the Institute Neurologic Research Biomedical in Kinshasa, they're the lead institution fighting Ebola, fighting COVID, fighting HIV. They're the front line of the Ministry of Health in the Congo, Democratic Republic of Congo, in fighting infectious disease and vaccines and development, and on and on. We partner with them. Continue. And then after that, at CONZO early on, I got interested in cerebral malaria, not just malaria exposure or complicated malaria, but in particular cerebral malaria. In 1997, I spent the summer in Senegal doing the first retrospective neuropsychological evaluation for our group in cerebral malaria exposure, school-age survivors. And we published that and then continue. That was that publication there when I was at Indiana. And then that became really the foundation later for the second Fulbright to go to Uganda, this time at the National Referral Hospital, Advance, to do a prospective study on the neuropsychological effects of cerebral malaria. I'm no longer directly involved with that research program at Macquarie University Malago Hospital in Kampala, but that research program and my original collaborators continue in that work up to this day. Continue. We looked at brain effects and neuropsychological to target specific brain effects from cerebral malaria. I worked in partnership with Professor Chandy John, former last year's president of American Society of Tropical Med and Hygiene. He was looking at the immunopathogenic effects of cerebral malaria. I looked at the neuropsychological effects. We tried to use neuropsychology to tease out immunopathogenic effects of cerebral malaria in the acute phase from hypoxic ischemic effects, which is a predominant theory of how cerebral malaria damages the brain. And we also looked at long-term follow-up. We document neurocognitive sequelae or symptoms of cerebral malaria in neurocognitive abilities, even years later in these surviving children. And we did. Thank you. Continue. So that was my original team during my Fulbright year before we got our first NIH grant, our 21, the brain disorders. And so we just worked on a wing and a prayer and a hope that we could leverage what we were doing into the resources needed to really build the kind of full-fledged research program, which now continues to this day at Malago and Macquarie University in pediatrics. We're based in pediatrics now. The person second from the left, Paul Bengiana, was my first hire the day after I arrived in Uganda, August of 2003. And I told him at that time, look, I can't pay you much, but if you stick with me, I'm thinking you'll become Uganda's first neuropsychologist. And he did through a joint program with Macquarie and Karolinska out of Sweden. And now he's the chief clinical neuropsychologist for Macquarie University and really handles basically all of their infectious disease clinical work, oversees all of that through Macquarie. Now he's based in the psychiatry department. Continue. Continue. Yeah, I'm going to skip through this. I don't want to take too much time here because of where we're at. I need to keep track of the time. Keep going till we get to the next slide. Yeah, I'm going to keep track here. when I give enough time for Q&A. So that was the end of our Fulbright year, 2003-04. My wife and I, and now those are the year in the Congo in 1991. My son Matthew was just a year old, you know, and then our third born was 3, and then by the time we went back for the year, they were both in high school. Yeah, so they can remember Uganda a lot better than they remember the Congo. And then if the embassy hosted a final farewell party with our team of collaborators, which grew a lot after we got our first NIH grant that year. Chandy as PI and me as his co-PI supporting him, and we were able to really, in March of that year, really upgrade from my Fulbright project to an R21, building on the Fulbright that became an R01 a couple of years later, that expanded to a U01 and continues to this day for advance. Yeah. So that was our full team in a spring workshop where we documented that if you didn't manage seizures really well during the acute phase of cerebral malaria when children are in coma, high risk of seizure, and that was your worst time for brain injury in these kids if they weren't being monitored, and if you didn't have the anticonvulsants prophylactically even to manage the seizures during the acute phase while the kids were, after being admitted, when they were in coma, and even after. And even many seizure effects were kindled long-term as a result of the acute cerebral malaria and surviving it in these kids. And we documented that as well. So Cheney's front and center, and Paul and I to the right, and then all of our Ugandan collaborators, nurses, pediatrics residents, faculty members in pediatrics and in psychiatry, acute care ward at the emergency room in pediatrics at Malago. I mean, on and on. It takes a village to raise a child, and it takes an entire hospital community to do this kind of project prospectively. So real great memories of that time. That was at the African Hotel downtown when we did a final workshop there to capacity build, train all the medical staff on seizure risk and complicated malaria and seizure management, and why it was important neuropsychologically advance. So we published, you can't see the very top, but we published a lot of our prospective work during that period. It was highlighted in different neurology and neuropsychological publications. Because we were the first to really do this kind of thing prospectively. And really, that was a major reason why I was brought to Michigan State, was to work in Malawi with Terry Taylor and others to help develop a lot of our Ugandan protocols and processes and neuropsychological capacity that we had done in Uganda during my Fulbright year on 2003-04, to develop that with the Michigan State University Cerebral Malaria Research Program in Blantyre, Malawi, which has continued under the overall direction of Terry Taylor up to the present day. And we did that. Again, I no longer work directly with that research program. We're actually doing pediatric HIV now in Blantyre. I'm doing that more through Johns Hopkins, but we did accomplish establishing a lot of the foundational work in Malawi and Blantyre that we had done together in Uganda. Continue. So now, interventions. We're training. Our present work involves computer cognitive games and apps on tablets, which Bruno now is to the far left. This was pre-COVID, one of our last Ugandan trips together, training our cerebral malaria team, which was implementing our original 5-year NIH project with cognitive interventions and rehabilitation of survivors of cerebral malaria in children that had graduated from Chandy's R01 neuropathology program. We then We're able to enroll many of them into an intervention program looking at neurocognitive rehabilitation, trying to adapt many of the intervention techniques that have been pioneered here in the States with ADHD and learning disabilities and so on, but doing those with infectious disease survivors and in particular cerebral malaria. And we continued that work later, and that's what we're doing presently with pediatric HIV survivors that have reached school age. Continue. So Terry Taylor, meanwhile, and her group continued to look at, with the use of their brain imaging, their MRI, which was, that capacity was developed in large part through College of Osteopathic Medicine here. At the time, and the only brain imaging for cerebral malaria work available outside of South Africa throughout the entire Sub-Sahara at a public hospital. And so the next steps involve looking at neuropsychology as it related to their ability to document the extent of brain swelling and its contribution to morbidity, but mortality as well in surviving cerebral malaria children when they reach school age. Continue. I could spend a lot of time on this if you were an audience of neurologists, but we'll skip this one, yeah. So now we're doing pediatric HIV in cognitive rehab on the basis of neuropsych, an NIH-sponsored study following up early treatment with antiretrovirals of children perinatally infected into their school age years. We're still publishing that work, NIH-sponsored. A multi-site study at 9 different languages, 6 different sites in 4 different countries. They're mapped out here: Malawi and Uganda and Zimbabwe, and a couple of sites in South Africa, and also, well, several sites in South Africa, and then also we had an early Zambia site that we're now trying to come back to advance. So that work has been the foundation of cognitive games intervention, which again, we're doing presently in 2 countries and hoping to expand that to other sub-Saharan countries by virtue of cloud-based technologies, yeah. And embedding that within machine learning and artificial intelligence to help customize precision neurocognitive rehabilitation through these kinds of apps in real time, cloud-based. And that's our current grant proposal, with partnership with the Games for Entertainment and Learning under the direction of Brian Wynn in the Communication Arts and Sciences. Yeah, advance. So we've looked at also early caregiver trainings in very early childhood, both cerebral malaria, HIV, what to do to enhance neurodevelopmental outcomes with not so technical of an intervention, but just spending weekly time with the moms, helping them understand sustainable, practical ways day by day in the homes that they could really enrich and enhance the development of their children at risk for whether for Konzo or for cerebral malaria or pediatric HIV. And that's been a whole nother research direction for us that I don't have time to deal with today, but if we get a chance to talk again about this work, I could really focus a lot more on that, because setting that trajectory in very early childhood gives you a lot more bang for the buck in terms of cost benefit over the long term throughout the lifespan. And we've got a lot of evidence now to demonstrate that. Now that we've been able to follow survivors from birth right up through into adolescence now over the years since coming to Michigan State, survivors of pediatric HIV, cerebral malaria in their preschool years, usually 2-3 years of age, 3 years of age on average, going forward, and then Konzo disease from the time they're weaned from mother's breast milk to cassava porridge, and then toxic levels of exposure there for Konzo disease in the Congo. Advance. So it's specialized tests for looking at early childhood that we validated in all of the countries that I've talked about or noted thus far. Advance, advance, advance. Yeah, so our school age testing in combination with cognitive games, advance, and computerized testing, both audio, visual. We're doing a lot of now combination of that with eye tracking. Let's advance to the eye tracking, and I think I'll finish up with that. So in the cognitive games in pediatric HIV, we're able to pioneer the use of other kinds of eye tracking technologies, screen mounted, very portable, which gave us an understanding, I think, better understanding of how important, as a measure of attention, which is sometimes hard to gauge in children on a real-time basis. Advance. We could validate the games and see their effects and their benefits. We did this here, with our colleagues at Games for Entertainment and Learning, Brian Wynn, and one of his top programmers, graduate students, and then some of my colleagues, and then my colleague Bruno Giordani was lead on this particular paper. Advance. We've got Brian and his team of programmers working year-round, but especially during the summer, student programmers have really expanded and developed with the help of 5-year NIH support that we're now going to hope to leverage going forward. Advance into a game package. And now we're looking at how to combine these games with eye tracking, TOBI eye tracking, and establishing the feasibility of that in resource-constrained sub-Saharan African rural clinics, health clinics, for example, and seeing if eye tracking measures of attention and recognition. There are some basic measures of memory for human faces, for example, and other kinds of attentional measures in really young children. This is an older child for the sake of this picture, but we've been able to publish feasibility studies with our medical students who've been able to work with me in Uganda in the summer, and then expand that into now how predictive they were of how the kids develop into their school age years neuropsychologically. Advance. And this is some of the conclusions of our eye tracking. I won't take time to read that. I'm going to skip ahead to my conclusion to give you time for question and answers. But bottom line is it is feasible, very powerful predictively. It does seem to work now with other kinds of biosensor technologies on the tablet or smartphone or desktop or netbook, where you've got stable power in the clinic facilities to really maintain that. Advance. We've published chapters on all the work I've described to you in our Bruno's in my co-edited book, the first of its kind in 2013, The Neuropsychology of Children in Africa, Advance. We use that as a textbook, by the way. And then there was a special issue in Lancet, sponsored by Fogarty, Brain Disorders Across the Lifespan. And we had, I and a group of other physicians, scientists, researchers were able to publish the chapter in this special issue in the Lancet that especially was dedicated to neurodevelopmental assessments and disabilities globally, but with a special emphasis in Sub-Sahara. Advance. So I want to end with this quote from George Bernard Shaw, but made famous by John F. Kennedy in his presidential inaugural speech. Advance. Some see things as they are and say why, but others dream things that never were and ask why not. Advance. At the beginning, 1989, I took a bunch of tests I borrowed from the University of Michigan just to make the trip tax deductible. Wondering, can we even do this stuff? Does it even matter? Does anyone even care? Beyond keeping kids alive up to age 5. But since that time, neurodevelopmental and neuropsychological assessment as part of public health interventions and outcomes has really become a core domain. And for that, we're really grateful. Advance. Thank you. Advance. Yeah. Okay. Yeah, I think this takes us right to almost 1:45. 3 more minutes. Oh, more slides. No, no, just kidding. Yeah. So I let the moderator, whoever should moderate questions. So if that's Emily, if that's John, yeah.
Yes. So most of you who are returning to Town and Gown will know the drill for asking questions, but for those of you who are new, we have 2 ways you can ask questions. Well, I guess perhaps 3. The first way is you can type your question directly into the chat box and I can read it aloud for you. Or you can put in the chat box, you can just say, I have a question, and I can call on you, and then you can voice it aloud. Or if there's a pause and no one's speaking, then you can also just unmute yourself and speak your question aloud. So does anyone have a first question?
You're going to have to unmute me. Oh, yeah. We're good. Okay. Yeah.
Michael, could I jump in and ask?
Sure. Yeah.
You've done a lot of work on testing and also interventions. Can you give a sense of the scale of the improvement for different conditions with the interventions that are used?
Yeah. In terms of whether it's clinically meaningful or not, it's a question that often comes up. We don't have true norms that are African-based for unaffected children countrywide. That would help you gauge the clinical impact of different interventions from before to after. But we do use American norms and then other reference groups within that health and cultural context in that African setting. Non-affected, normal controlled children, to help kind of adjust our scores on the basis of age and gender. And between that and American-based norms, which you have to be really cautious about, which are used widely. I mean, they sell these tests to clinicians and pediatricians for clinical assessment and categories, diagnosing disabilities and qualifying kids for disabilities. And their clinical impact becomes a really important question on the basis of individualized assessment. For us, and research is by group and anonymously and so on. But typically we're looking for about a moderate effect size as they go within the statistical world. Yeah. And so maybe an effect size, I don't know if in terms of ADAS, I don't want to get too statistical here, but looking at about a 0.3 to 0.4 moderate effect size. Sometimes it's weaker than that, and we have to understand why, and looking at further kinds of predictors analytically in our modeling of our intervention versus our neuropsychological neurodevelopmental outcomes. But by and large, it's a moderate effect by group. For an individual child clinically, if we could customize our interventions more to the child, and that's where machine learning and artificial intelligence might really be able to help us with a wide array of medical, immunological, microbiome, biogenetic. I mean, that's now coming into play. Leading groups are looking at all of those data in a machine learning paradigm. In pediatric HIV has been the lead there. Then if you can customize your interventions, both medically with antiretroviral combination treatments early on, and behaviorally with, say, cognitive games or caregiver training, combining those, you can get a significant effect size, and that we're seeing good evidence now for that. Yeah.
Suzanne has a question, which I also had, which is, what are the interventions that parents, caregivers can do at home with children? I think, some of these cognitive activities.
Yeah, well, UNICEF and WHO partner to develop 10 years ago now is when that work began. Began as care for child development. I was at the international conference in Istanbul in pediatric global health where they first sort of did their launch of these intervention packages. Basically manualized materials available for free anywhere in the low and middle income country, developing world, with probably about 6 different intervention training lessons or packages, which community health workers who going into the communities for at-risk families and children could work with the moms, and over, say, 6 sessions of primarily play therapy, but also nutrition. That was a combination of the two. That's really been the big push for UNICEF in the early childhood intervention world. So manualizing, scaling, making it to scale, making it accessible and affordable, and then mobilizing community healthcare workers to go in and actually train them to do this with moms as part of their other child wellness intervention programs, or standalone, depends on the country. They can usually 6 minimum for any kind of measurable impact, which is not moderate or significant by any means. If you could sustain that training and really continue to follow up and do booster sessions like vaccines booster, with these training sessions on an intermittent basis with the moms over the course of a year, our training was a different model than what UNICEF uses. Ours was weekly. It was very intense, based on Nina Klein, developmental psychologist at Bar Ilan University in Israel, who devoted her professional life to her approach, mediational intervention for sensitizing caregivers, which we still use. We're using in the Congo, using our Ugandan experts to train our Congolese field teams, south to south, which has been a real source of encouragement for us to see that working. Anyway, you could do it year-long, weekly, and really see dramatic effects beginning after about 6 months, but very labor intensive, very expensive, not hard to scale that up and sustain it. And unless you do intermittent booster training, you do lose the effects gradually over time, the neurodevelopmental benefits. Moms drift back into other patterns. Plus kids develop, they get older, they get into school, less success for the mom. Teachers now, you have to train them, and yeah, it gets complicated as kids get older. But minimum 6 a year would be great, weekly, but that's not really very practical. And somewhere in between now, combining nutrition with caregiver training, a lot of how to develop games and toys in the home that are out of whatever objects are available, and training moms to be creative and in that regard. Yeah, kind of a convoluted answer, but you get a feel for just how messy but yet powerful that can be. Yeah.
Let's see. John, I will come back to you, and Judy, I'll also come back to your question. I just wanted to skip ahead to a question that I think is related to what we're currently talking about, which is, Dr. Boivin, have there been any attempts to integrate some of these interventions into the education system, like you were sort of we just touched on with teachers doing these in classrooms or one-on-one with affected children?
Yeah, Nina pioneered those in the preschool setting. In fact, the whole country of Singapore implemented her MISC, Mediational Intervention for Sensitizing Caregivers system, in the late 90s, 2000s. Nina Klein, by the way, passed away about 10 years ago now, unexpectedly from aggressive cancer, but was a winner of the Israel Prize, which was Israel's kind of Nobel Prize given to lifelong achievements and contributions in the sciences. So she did some great work over in this area. And what was really interesting was seeing her and her team at Bar Ilan implement it within preschool, daycare, up into the school age. Now, at the end of Nina's career, before she passed, they were pioneering its use with caregivers of those in early stage Alzheimer's and with more, age-associated dementias in terms of enhancing caregiving there in those final stages of life. And so across the lifespan, in any kind of institutional setting where you've got access and you can train the caregivers. We just finished an NIH project in Bloemfontein, South Africa, where Nina and her team, Nina had passed away by then, but her successors at Bar Ilan, working with our team of Michigan State from Uganda, and then also training local folks in their Ministry of Health, implemented the caregiver training in community child care centers. After school, there's a national program in the Republic of South Africa where kids could go to this sort of setting before they go home, where they could get meals, get nutritional food, do their homework, get support, get some tutoring. It can vary a lot. These community centers in Bloemfontein and throughout the townships, they're very common. And so we just finished a study implementing that in these community centers for school age kids, and now have submitted a competitive renewal that is pending. We hope can get funded so we can build on that work, doing it from older middle childhood into adolescence now in these community centers. Were kind of our in-between places for kids from school before they get home. And that tends to be a really strategic point to reach these kids. It's very late in their development, but it's a very strategic point, combining that then with other kinds of academic and nutritional services for these kids that they're very much in need of in those settings in South Africa and really probably throughout the Sub-Sahara. Yeah.
Okay, John, you want to go now?
I'm just wondering, I've done a lot of work in Uganda. I'm a dentist, but I've been peripherally exposed to medical clinics, all very rural. Most have, if they have any electricity, is not stable. I'm just wondering, how widespread is the cognitive impairment?
With cerebral malaria, we found that in surviving children, 1 out of 4 had a significant cognitive impairment in one of 4 major domains that we looked at, even 2 years after and beyond. I mean, when we enrolled those kids 3, 4, 5 years later in cognitive rehabilitation programs, we still saw those impaired domains persist, largely working memory, attention, some executive function, reasoning, planning. It depends. On pediatric HIV, it's more pervasive and more profound long-term, even with kids that you can reach in infancy now with combination therapies, antiretrovirals, diagnosing them literally in the first few days of life now and now treatment is mandated as soon as you diagnose, even before, prophylactically while in the womb with the moms to prevent vertical transmission if you can. Anyway, the pediatric HIV, it's if they get early and sustain antiretroviral treatment and good medical support, and the kids in our studies do because they're part of these research programs. It's not the standard of care, so to speak, that the general population with affected children would receive. They're in research programs. They're being seen monthly. The moms and the children are being carefully monitored medically. The moment they get any kind of, comorbid illness, they're being treated, for free, effectively. So this is a very special group of kids. But even in those kids who have the best medical care that could be available to a pediatric HIV surviving child in Africa, we saw very significant prevalences in the order of half. Now, it was not, the earlier they got treatment and the more sustained and the better the medical support, the milder the neurocognitive impact. But with the right tools, you could still see it. Even in exposed, uninfected children now, and there are millions of them just in Uganda and in East Africa, Tanzania, Kenya alone, tens of millions throughout that region of East, Central, West Africa. That's the main concern now, is we're getting really good at preventing transmission of HIV in infants if moms can access treatment during their pregnancy. But it's now you're left with millions and millions of exposed uninfected kids, and what's their risk? And there's been a lot of research that we've been a part of in other groups debating and looking at what's the risk of exposed uninfected kids and what are the major sources of risk and how do we mitigate that risk? And it turns out that you've got a 20 to 30% risk even in that group when compared to unexposed, uninfected kids that are matched within those cultural, language, and economic settings. Yeah, I hope that helped. I mean, it's kind of a convoluted epidemiology. By the way, I was in the Congo that Fulbright year, one of the greatest public health impact I saw during my year there was not an infectious disease, but a dentist who came and volunteered his time over the period of several months, and retired dentist. And it was unbelievable because there with when you ground up cassava flour, a lot of grit and sand, and their teeth are really worn down, and a lot of dental needs, not from sugar, but from other kinds of hygienic practices and infections within that type of cultural setting. Yeah. Anyway, I just brought back a flood of memories when you mentioned that. Yeah.
How practical do you think this the intervention is? I can see Malongo Hospital as being able to effectively do the intervention, but how practical is it to get out into the rural areas?
If we can get it on smartphones, our gel lab, I mean, they're working on prototypes now and adapting that to tablets, which almost every village now is procuring. I mean, the internet via mobile networks is not a problem. I mean, Africa's far ahead of us actually, because they've had to move directly into mobile networks for communication, and yeah, and the Chinese have really pushed it too, the 5G networks, and that's a whole nother conversation for another time. But they've got great mobile network coverage, and everybody's got a smartphone. They have a whole, and it's expensive for us, but not for them. They have a pay-as-you-go system, and a lot of support through multinational mobile network companies to make the equipment far more accessible. So, and then linking that now we're trying to establish a real-time cloud connection. And if we could really get those kinks worked out through when we're pioneering some of that work here, Brian Wynn and his colleagues here at Michigan State, if we can really get that, then accessibility, affordability, adaptability, availability, all those big A's within public health interventions can all be achieved with these kinds of cognitive games, because the foundational capacity is there within the population. It's just now interfacing that in an affordable, sustainable, adaptable way. That's the next season. We're some years off from that still, but it'll happen. Yeah.
Thanks for your great work.
Okay, and Judy is wondering if I'm sure that this varies from country to country and over time, but could you give us some sense of the prevalence or even the incidence of the cognitive impairments that result from some of these conditions, from the cerebral malaria or Konzo?
Yeah, I haven't talked much about Konzo, but the most serious level of cognitive impairment we've seen actually is not in kids, even when we were looking early on at kids who had survived beyond 5 years of age with HIV in the absence of treatment for various reasons, because of the criteria for treatment at that time, which looked at certain CD4 thresholds at that time. And this is in the early 2000s. But what we saw in the Congo with Konzo disease in the villages was it far surpassed the level of disability I've ever seen anywhere else in Africa. It was just profoundly heartbreaking. And it's because Konzo, in part, because, I mean, when you have to subsist off of a basic food staple that poisons you slowly, unless you go to great lengths to detoxify it every single day, every single meal of your life, and that of your family. I mean, there's no other culturally or agriculturally or ecologically sustainable alternatives, really. That is the most severe kind of poverty. So a neurotoxic exposure over the lifespan of a child, the impairment of the mother, because the mother's more affected now and can't care as effectively for the child, in a resource-constrained setting in the village where the lifespan of disabled persons can be far less than non-disabled persons because they don't have the support social safety net, in providing care in that kind of harsh eco-social setting. Really about 2/3 of these Konzo kids were with discernible neurological disease, had profound neurocognitive disability in at least in one, usually multiple domains, as well as we use a neuromotor proficiency task as well that had never been used. It proved a lot more sensitive than the neurological exam. So if you were, again, an audience of neurologists, I wouldn't say that, but I think I can with this group. Our motor proficiency exams within neuropsychology were far more sensitive in picking up the preclinical Konzo onsets in our kids that were not yet neurologically diagnosed with Konzo. And the combination of compromised caregiving of the mom, the most severe kind of poverty and the worst kind of eco deprivation setting, other kinds of comorbidities then in that weakened state, a lot more malaria, a lot more HIV, a lot more malnutrition, a lot more micronutrient deficiencies, on and on. That combination, of which Konzo was the tip of the spear for our studies, was the worst I've ever seen in the Sub-Sahara. And that's why it's, in my mind, the most important work I think that I do. There are lots of people that can now do what I do in malaria or HIV or malnutrition, and they do it, and they've got more resources, far greater research programs, and bigger capacity, and they're working in Uganda and everywhere else where I've worked. But we really are the only folks doing anything significant in the way of interventions on Konzo in the Congo. And because it's just so hard to do, and it's such a remote, difficult place to do it. And that has to be the greatest and most tragic human need I've ever witnessed, even up to the present. Yeah.
And I have sort of two related questions to that. With Konzo, is there a way to physically tell, which cassava crops have these high levels of the cyanide, or is it you just harvest it and you don't know?
Well, we can, I mean, in research, of course, we measure toxicity within the flour. That's what it turns into, the basic cassava porridge and or food staple. And we, with all of our study households and kids and families, we look at the cyanide level, toxicity levels, and they're Bradbury from Australia really developed the first field kits that were adaptable, that we helped validate. Not me, but the group I work with validated decades ago in the Congo. We could actually go in and kind of a litmus test the cassava flour in solution and gauge the toxicity level. And so in terms of sustaining surveillance and monitoring of how well the moms who have been trained to detoxify their cassava daily through the wetting method, how well they keep doing the wetting method when you're not around, and you measure their flour, but they could gauge it themselves if we had, we could train them, and we've piloted some of that where they could actually test the cassava, or anybody in the village leader or chief or elder could go into any household and actually test the cassava flour in porridge and gauge how well the moms are doing in detoxifying it, how risky it is in cyanide levels nutritionally. And then from there, once we know the level, we know the risk. We've done the dose response stuff quite a bit, actually. Yeah.
So are the women who are creating the flour then just encouraged to treat every harvest like it could be?
Right. They use the wetting. It doesn't matter how well they think they've prepared or detoxified, because you can traditionally, when you harvest the cassava tubers, which grow below ground, and you peel them, you soak them for 3 days, and they ferment in water. And then you dry the peeled tubers in the sun, at least for a day or so if there's sun. If not, you don't. And that's assuming you're not on the move because of military instability in the area, and you grab your cassava and you're on the run in the forest, you're eating as you go. If you've got a stable social situation where you've got the time and you're not starving already, the traditional way of preparing the cassava is harvest, peel it, soak it for 3 days. It takes 3 days for it to ferment sufficiently to break down the lanamarin of the tubers in water. And then you dry it in the sun, and then it's pretty much safe. There isn't really enough there, at least in the short term, even in the absence of other kinds of sulfur-based amino acids from beans or meat within a diet. It's safe. But the problem is, and the bitter cassava it is robust and resilient in drought and acidic and soil conditions, and that they grow, that thrives there, that was not indigenous actually to the Congo basin. It was brought by early Portuguese traders from the Amazon basin. And the problem is when, and within the Congo basin, when you have to subsist off of bitter cassava, you get enough calories to feed your family, but not the micronutrients and the risk then of toxicity. So what do you do? The problem is, when I was there in 1990-91, everywhere I went where there wasn't Konzo, this is how they would prepare the cassava tubers: soak 3 days, dry for a day, then pound it into flour for storage. If you did something else like steam, like chikwanga or other types of techniques of preparing where you boiled and steamed or stored. Then it was safer that way. You could break down the lanamarin with the toxic cyanide to where it could be metabolized without penetrating the blood-brain barrier with toxins. Okay, so when you do that, and they did it traditionally, and I would ask them, well, why are you doing it this way? And they would say, that's just how we do it. It was a cultural tradition that had evolved over the millennia, the social practice. There's your medical anthropology, if you will. But then near the worst area of outbreak, near the Angolan border, there was such movement across the border, the frontiers from Congo to Angola, first during the Angolan Civil War, during the Congo Civil War, and still to this day, depending on how bad the lockdowns are from COVID or economic hardship or famine or drought or whatever, these populations are moving back and forth. A lot of disruption to their social structure. So they don't remember to do the soaking, and they don't remember why. And so when we go into a village area to train on a wedding method, every mom does it every time. But that's what makes it so labor intensive and makes recidivism, so common, and why a good sort of maintenance program is so much needed, combined with surveillance of just how toxic is the flower, week to week, month to month, village to village. Yeah.
On another related note, what kinds of nutritional interventions are being employed? And this doesn't necessarily have to apply just to Konzo.
Well, I know that Gates has funded in the past, and Ohio State was one of the leading genetic engineering of cassava to detoxify it. The problem is, again, scale up and getting it there. By the time you could take a genetically engineered brand of bitter cassava that's non-toxic and establish it all over the Congo Basin, I mean, you might as well just establish something else, prevent it entirely. That's the kind of resources it would take. So that's why it's a great idea, very attractive, but the scale up implementation and sustainability of genetic engineering, because villages are in the area where we work, they're very particular about their cassava. They don't like you messing with their cassava that they know that they're tried and true strains that they've generation after generation that they've cultivated and are familiar with. Non-toxic varieties that are like in Uganda, they use a sweet type of cassava, but they have so many other kinds of foods. They don't have to rely on a bitter cassava to prevent starvation. The non-bitter cassavas in East Africa, other parts of West Africa, the problem is that they're very vulnerable to fungi and other crop diseases. So they don't withstand drought very well. So I was a few years ago, before pre-COVID, I was in Uganda. And virtually their whole cassava crop in Uganda had been taken out by a black fungus. Thankfully, they had lots of other things, matoki, millet, and they had rice, and they had beans, and they had other kinds of staples that they didn't have to didn't hardly made a dent in their diet, although they missed it. But there's more of a preference of palate, So what do? I know that they're in Rwanda, Michigan State, also in Tanzania, has worked with genetically engineered types of legumes or beans that would do well in acidic soils. And I've tried to reach out on occasion when I've had the bandwidth to partnering with some of their crop engineering work here, because really that's the direction it needs to go. They can't, you're really, in the end of the day, you've got to have things that people will grow that's affordable, accessible, adaptable, and scalable and safe and nutritious, better nutrition than just the starches of cassava. Legumes, I think, are the answer. Just got to get a good start, a good partnership with whoever in the Congo, and unfortunately, we just haven't gotten that level of traction yet. Been too unstable, and parts of the world that do have the resources have been more interested in mining the minerals of the Congo than growing new types of safe foods. Yeah, so.
Any more questions?
If nobody else has one, maybe I can squeeze in another. Before coming here this afternoon, I was showing my students what I think is a brilliant documentary called Fire in the Blood, about the more than a decade after antiretrovirals for treating HIV were available in the West, that they were denied to the vast majority of people in Sub-Saharan Africa and elsewhere because they couldn't afford the roughly $15,000 a year price tag. And I know that the claim is often made that the policy of pharmaceutical firms in the West cost something like 10 million lives around the world, people who died unnecessarily. You mentioned that very early on in your career, you were thinking of pharma as a career option. Once you'd been in Uganda and seen the effects of HIV, how did your position change on that career possibility?
Well, it took 1 month in 1989 in the Congo to change my life. Yeah. It was like I went to another place. I'd never been outside, except to Canada, where my folks are from, Quebec. But beyond that, I had no idea, no clue what my wife had experienced growing up, or her family, It was a huge relief to kind of lure her away from the, Peace Corps. Anyway, but when I went, and firsthand before folks retired, which was her, her strong desire, we as a family could go and see, and then that changed my life that month in the Congo. And nothing's been the same since, up to today and here. Were it not for that trip, we wouldn't be having this conversation, as I say. But I don't know. I'm not going to tell you anything you don't already know. I mean, just witness COVID, the vaccine thing. Whether that's been, I'm going from preaching to meddling, so I better be careful here. We're online, and I want to keep my job. Yeah.
Be authentic.
Yeah, but the federal government invested a lot into vaccines, and the pharmaceuticals accepted that for their R&D. The promises that we're going to make these available throughout the world, and you be the judge of how available those COVID vaccines. So, I want to talk about pharma and greed and being niggardly stingy with the rest of the world, and going really with those who can pay, or for whose government can pay. Look no further than COVID over the last couple of years. Yeah. I will share one personal account. That year in the Congo, Pfizer built a brand new clinical research facility for their clinical trials in adult HIV at that time. Clinical trials at Malawi. I watched that building go up, and it was amazing. I'd eat, I remember one day a lunch that I had with a physician scientist who was one of the lead researchers, young guy from Hopkins, I think. Doing a lot of their clinical trials work that was beginning to take place in that facility that was dedicated that year. Yeah. And Pfizer built that thing, and then they handed it off to the medical school, and they let them take charge. But it was to validate all of their new generation of antiretrovirals. Well, the scientist told me, he said, we've pushed, the humanitarian public health minded physicians doing this clinical trial work on adult antiretrovirals. The first combination ARTs were being clinically validated at that hospital at that time. But he said, we want to, make these drugs affordable and for the local population. And even though the drugs are being validated with Ugandan adults living with HIV in that setting, at great benefit to them, there was absolutely no way that Uganda was going to receive any discount on those drugs from Pfizer. So that was my first encounter with that kind of disparity of what you're describing in the Fire in the Blood documentary. Yeah, it's real, and we saw it firsthand. And but again, I mean, you want to start somewhere right here now. Let's start with COVID. Yeah. Or is that too close to home? Sorry, I couldn't resist. Oh, I got will you give me a job if I don't have one tomorrow? You got any openings in social studies? Yeah.
Have you worked with Tuasigi Paguri and the Nyakan Project?
I know him, yeah, and I'm on his email list. I've met with him. I've got the book.
I think he's done pretty incredible things.
No, tremendous. Yeah, tremendous work. Yeah, I would agree. And that's really that kind of NGO work is really the future. Those kinds of partnerships, fully sustainable and not, it's great stuff. And that's really the future of public health in these settings. That's the only way it's really going to work long term. Yeah, and it's holistic. It's a complete package. It's everything. Thing is, it's hard to get complete packages funded because peer review groups think you're trying to do too much and you need to be focused, and you get, you're just dead in the water the moment you just try more. Now that's changing with modeling through machine learning, modeling power and measuring a lot of things is no longer the kiss of death in these kinds of research programs. Which are the foundation then to make them evidence-based to become intervention programs. Because everything has to move from assessment to intervention to evidence, or else, again, you're dead in the water. Yeah, but no, that I'm familiar with it, and it's great work. Yeah.
Is anyone following through, judging the positive social outcomes of the rehabilitation that's being done for various groups that have disease? Where do these folks fit into society? How do they interact? Are they married, etc.?
Yeah, over the lifespan, there's a really, I had some close colleagues that just got back from Uganda. I haven't been in a few years now. They just got back, and the Belgians have pumped a lot of money into autism work. And they've actually developed all the schools, the public schools, all of the clinics within the hospital system, they've partnered with all the public Ministry of Health clinics throughout Kampala, and they're going to expand throughout Uganda. And what's really interesting is one of the programs they were describing. They actually visited these craft stores. I saw something like it. My Fulbright year in the Congo with tuberculosis survivors who were crippled, and these were women who were trained by a Catholic NGO to do crafts, seamstress things, and their crafts were sold in a major crafts goods store. And then later, I saw the same model in Laos in Southeast Asia with the Mennonites, and with the Hmong who were marginalized, but they trained them to take their exceptional crafts and Needleworks, which used to win in the Minnesota State Fair needlework for decades, of, when they were still in Minnesota. Anyway, where am I going with that is that training in life skills with these autism adults or in other kinds of neurocognitive sort of disabilities, if you will, that's being done now with this Belgian NGO, and they're building crafts. They have other kinds of cottage industry type things that have been scaled, and now they take school age kids under their wings and train them, and so that they have a direction and a future and an income, and that kind of adult to child mentoring in a sustainable cottage industry that's marketable and that can eventually find its way to, the internet marketing and Amazon and wherever wherever you do your shopping is a wonderful model. I saw it in its very early stages in the Congo with polio survivors, and now with autism and other disabilities, that there's been a big push. And obviously any survivor with neurocognitive disabilities of any infectious disease or early brain trauma, that could be a great direction. I'd never seen it. That was all during COVID when they were locked down. Pretty amazing what they accomplished there with the Belgians that during the last couple of years. Been huge.
Any further questions?
Well, I've got a few, but I'll save them. I don't know if we go past 6:30, John, I'm gonna have to charge overtime. I don't know if you can afford me at those rates. Just kidding. I'm sounding like the early pharma mega dreams, Mike.
Okay.
Yeah.
Well, I think we can draw proceedings to a close then. Michael, thanks again for an insight into a really admirable career. So it's a real honor.
I wish it really, to everyone I work with, especially my colleagues, none of this, and the dedication and the accidental anthropologist from my first year in the Congo. I wish I could read it to you here and now, but basically none of this would ever have been possible without them, without all who have followed the work they've done. They've borne the heat they've borne the burden in the heat of the day. All I've done is, I don't know what I've done, but yeah, they've done the real hard part.
Can you send me a link to the page with the
Sure.
PDF
Yeah.
and then I'll circulate it.
Yeah.
Thank you. And thank you to Emily as well for moderating. Great to have you back, Emily, in this role. And then just a quick announcement. Next week, Dr. Matt Pawley from the History Department, who's an expert on Ukraine, and at this point very well practiced in talking about the unfolding tragedy, will be making a presentation. So thanks again, everybody, for attending, and hope to see you next Tuesday.